Welcome back to the show, everyone. Today we are diving into the body's plumbing, specifically the stuff that happens when the drains get backed up. We are talking about the biomechanics of lymphedema. Dr. Sarah, are you ready to get into the weeds of interstitial fluid?
Always, Dr. Khan. While the cardiovascular system gets all the glory, the lymphatic system is the unsung hero of fluid homeostasis. For our students listening, this is high-yield territory for the boards because it bridges the gap between basic anatomy and clinical pathology.
I love that. Now, let's start with a clinical picture. Imagine a 60-year-old patient who had a radical mastectomy and axillary lymph node removal 5 years ago. Suddenly, her right arm is heavy, swollen, and her skin feels tight. That's lymphedema in action. But Sarah, let's go back to the why. Give us the precise mechanics.
To understand lymphedema, you have to understand the Starling forces. Normally, high pressure in the arterial end of capillaries pushes fluid out into the tissue spaces, or the interstitium. Most of that fluid, about 90%, is reabsorbed by the venous end, but that last 10%, that's where the lymphatics come in.
Right. I like to think of the lymphatic system as the overflow drainage for a high-pressure irrigation system. If you're watering a field, some water is going to pool in the low spots. The lymphatics are the little ditches that carry that excess water back to the main reservoir.
And it's not just water, Dr. Khan, it's protein. This is a crucial board fact. The lymphatic system is the only way for large plasma proteins that leak into the interstitium to return to the blood. If those proteins stay in the tissue, they create an osmotic gradient that pulls even more water toward them.
So it's a vicious cycle. More protein equals more water, which equals more swelling. Why does this matter clinically? Because unlike regular edema from heart failure, lymphedema fluid is protein-rich. Over time, this leads to chronic inflammation and eventually fibrosis. The tissue literally turns from a soft sponge into a hard brick.
Exactly. Clinically, we call that non-pitting edema in later stages. In early stages, you can leave an indentation with your thumb. That's pitting. But as the biomechanics shift toward fibrosis, it becomes hard and non-pitting. Students, remember Stemmer's sign. If you cannot pinch the skin on the dorsal surface of the second toe or finger, that's a classic indicator of lymphedema.
That's a great tip. Now, let's talk about the pump. Since the lymphatic system doesn't have a heart to drive it, how does it move fluid against gravity? I tell my students it's like a subway system where the passengers have to push the train themselves.
That's a vivid analogy. In technical terms, we look at lymphangions. These are the segments between two valves. These segments have smooth muscle in their walls that contract rhythmically, but they also rely heavily on extrinsic factors, skeletal muscle contraction, and even the pulsations of neighboring arteries.
This is why movement is medicine. When you walk, your calf muscles are essentially squeezing those subway cars upward. Why does this matter clinically? Well, if a patient is immobilized after surgery, or if the lymph nodes, the transfer stations, are removed, the whole system grinds to a halt. The pressure builds up, the valves fail, and you get reflux.
And speaking of failure, we have to distinguish between primary and secondary lymphedema for the exams. Primary is often congenital, think Milroy disease, where the vessels just didn't develop right. But secondary is far more common in the US, usually caused by surgery or radiation for cancer.
And don't forget the global perspective. Worldwide, the leading cause is actually filariasis, a parasite that literally sets up camp in the lymph nodes and blocks the flow. It's a mechanical obstruction at its most literal. I've become the doctor of choice for many of these cases, where we have to manage the long-term skin changes.
The skin changes are fascinating from a biomechanical standpoint. When the lymph stagnates, the local immune response is impaired because the highway for lymphocytes is blocked. This makes the patient incredibly prone to cellulitis. One tiny scratch can lead to a massive infection.
It's like a stagnant pond. If the water isn't moving, it becomes a breeding ground for bacteria. So Sarah, how do we fix the biomechanics? We can't usually grow new nodes.
We use complete decongestive therapy. The first phase is manual drainage, physically pushing the fluid toward healthy functioning nodes. Then we use compression. By increasing the external pressure on the tissue, we actually decrease the amount of fluid that leaks out of the blood capillaries and help push the interstitial fluid into the remaining lymph vessels.
It's like squeezing a tube of toothpaste from the bottom up. You're using external biomechanics to compensate for the failed internal ones. Why does this matter clinically? Because if we don't use compression, the swelling will always return. It's a physics problem as much as a medical one.
To wrap up the high yield points for our listeners, Lymphedema is an accumulation of protein-rich fluid. It happens when the lymphatic load exceeds the transport capacity. Remember the difference between primary and secondary causes, the importance of valves, and the transition from pitting to non-pitting edema due to fibrosis.
Spot on. The big takeaway, the lymphatic system is a low-pressure, one-way drainage system that relies on muscle movement and valves. When it fails, you get a protein-rich backup that changes the very structure of the limb. Thanks for joining us, Dr. Sarah.
My pleasure. Keep those subway trains moving, everyone.